Great. Thank you. Thank you very much. I really appreciate being here today, and I appreciate our faculty and all of our attendees on this call. I have the pleasure of introducing our three guest speakers, starting with Dr. Michael Dudas, who is actually the chair of the Pediatric Ambulatory Collaborative Steering Committee, which we roped him into a year or so ago. Thank you very much. He's a general pediatrician at Virginia Mason University Village and chief of pediatrics and deputy chief of primary care at Virginia Mason Medical Center in Seattle. Michael has been practicing pediatrics for 25 years in a primary care setting. So thank you. Dr. Scott Piazza joins us from the Central Coast of California. He is board certified in family medicine, works on the Central Coast, as I mentioned. He is the medical director for informatics for Pacific Coast Health Centers and serves as a member of the quality team for both local and national initiatives. He is also a faculty member for the Marion Medical Center Family Medicine Residency Program in Santa Maria, California, where he has helped train family medicine residents and medical students in both acute and ambulatory care. Dr. Williams, you have a very long and extensive CV, which is absolutely great. So I will try to touch the highlights. Dr. Williams is the medical director for the centralized operational support hub for the Texas Child Mental Health Care Consortium, coordinating the implementation of a statewide child psychiatry access network and mental health for youth in schools. So that's her first job. Maybe not first, but additionally, she is a professor in the Menninger Department of Psychiatry and Behavioral Health Sciences at the Baylor College of Medicine. She is also the training director for child and adolescent psychiatry at Baylor. Dr. Williams completed both her fellowship and residency training at the Baylor College of Medicine in 2004 upon graduating from the University of North Texas School of Osteopathic Medicine in 1999. She has received certain awards, which included the Woman of Excellence Award and a Norton Rose Educational Leadership Faculty Excellence Award at Baylor College of Medicine in 2001. And the Greater Houston, I'm not sure what NAMI stands for, but presented to Dr. Williams with one of the Heroes and Hope Across Greater Houston Award. That was in 2001. I'm sorry. So with that, welcome to all of our panelists, and I'm going to turn it over to Dr. Dudas.
Thank you. So welcome everybody, and thanks for joining today. We're really happy to have you. We had a really good session a couple of hours ago with, I think, 22 or 23 participants. And so we're glad to have all of you. It looks like a lot of people from the West Coast joining right now. So thank you for being here. I will start by putting in a plug for the Pediatric Ambulatory Collaborative, which is a work group from the physician enterprise that's been together for the past couple of years now. And our focus has been on the pediatric origins of chronic disease and how we can start to impact these during the first 2 decades of life. You can see the topics that we're really focused on this year. Really, the top of the list was behavioral health, and obviously that's what we're talking about today, but also trying to advance work around adverse childhood experiences, support for patients with eating disorders. We've spent a lot of time during the pandemic talking about respiratory viruses, firearm injury prevention, as well as weight management and obesity medicine. If you are interested in joining us for some or all of our collaborative meetings, we meet monthly, and there is a link there that Rachel's put in for you to connect with us. Next slide, please. There we go. So we're going to talk about depression in childhood and adolescence. And a real goal for this lunch and learn is to really more have a conversation, share some information and have a conversation about screening for depression in the pediatric population. I'm going to start by sharing why it is so important to screen in primary care. And then Dr. Piazza will talk about the depression measure that we have as part of Common Spirit and the work that's been going on to help support that measure. And then finally, Dr. Williams will be sharing information around the incredible resources that are available in most of the states that Common Spirit is in for accessing a pediatric psychiatrist whenever you need it to support the work that you're doing with your patients in primary care. So first, just to set the context, pediatric depression is common and it is increasing. I think as everyone knows and probably feels in their practices. This is data from SAMHSA, looking back at the most recent information from 2020. And what they found was 4.1 million adolescents. So 17% of all adolescents had at least one episode of major depression in that prior year. This really closely reflects the lifetime prevalence of major depressive disorder, which is 20%. And we know it doesn't affect all people equally. As patients get older, as you can see in the middle of the slide, the prevalence increases with 16 and 17-year-olds at almost 22%. And there is a fairly big discrepancy between female patients and male patients, with females 2.7 times as likely to have a major depressive episode as males. These numbers continue to increase. And we've seen that over the past 20 years, but it's really, I think we've seen it a lot during the pandemic in particular, as people have lost social supports and lost loved ones from the pandemic, and the loss of social connections that have happened amongst this age group. And I don't think we've seen the full impact that has had yet. But in 2019, mental health surpassed physical conditions in the pediatric population for reasons causing impairment and limitation. Next slide, please. So pediatric depression is often recognized late or not at all. Of these patients with depression, only about 50% are diagnosed before adulthood. And there's lots of reasons for that. Some of them include lack of awareness. There still remains stigma and societal attitudes about mental health. Often these patients just suffer in silence. It's not an outward expression often. And sometimes the signs are misinterpreted. Parents and providers can attribute it to just the moodiness of adolescence, but also the way adolescents present with depression is often different than adults. So in terms of the most common presenting symptoms, the top one for adolescents is loss of energy. And this doesn't show up in the top three for adults. Certainly there's depressed mood, which is common between the two, but insomnia is also a really big part of pediatric depression that is not as common in adulthood. Some of the differences in addition to that include change in appetite, so weight loss or weight gain. For adults, it's really more about loss of interest in activities and often loss of concentration, which impacts pediatric patients less. Next slide, please. So primary care providers are critical to identify and help manage pediatric depression. Of the patients who are identified during the adolescent time period, the 50%, of those, only just a little over 40% receive any kind of treatment at all. And in large part, this is due to the limitations of our workforce that help support pediatric mental health. The map that you can see there on the right looks at the number of child and adolescent psychiatrists by county throughout the United States. The red, which is the majority of the map, represents no child or adolescent psychiatrists available at all. Orange shows a severe shortage. And if it's possible to zoom in close enough to see some of the counties, you may find some yellow and green areas, but as you can see, there is a real lack. And I think this is just representative because there's often not enough pediatric psychologists available, pediatric social workers. So it really, because of this, it's really up to primary care providers who are seeing these patients in their offices to recognize depression and begin to manage it. There was a study back in 2001 looking at the attitudes of primary care providers and their role in identifying and managing depression. Most, 90%, felt that it was important that primary care providers recognize depression, although half of those lacked confidence in being able to do so. Of those, though, only about a quarter felt that they were responsible for treating, and about half of those did not feel confident in actually treating pediatric mental health. So there's been a lot of work over the past 20 years to try to find ways to support primary care providers in identifying and managing mental health in this population. Next slide. So we just wanted to ask everyone to answer a few poll questions, and Rachel will pop these up on your screen. But first, just so we have a sense, do you routinely screen your patients for depression during your well care visits? We'll give everyone just a minute or so to answer that question. Okay, so 80+%, which is really amazing. And then most of the others do it sometimes, so probably depending on what's going on and possibly how their flow is going that day. So that's amazing. Next question. Do you routinely screen your patients for suicidal ideation? So about 60% do, close to 20% don't, and the rest sometimes. And that's incredibly important because even in the app, I mean, while depression is probably the biggest risk factor for suicidal ideation, the frequency of suicidal ideation is actually higher than the incidence of depression. Next question. Do you routinely initiate medication management for your patients with depression? So about a quarter of you do, and close to half don't, and then the other third sometimes. Thank you. And then we have two more we can jump through. Do you routinely recommend lifestyle interventions for your patients with depression? Let's see that. So most everyone, which is fantastic. And then lastly, do you routinely recommend evidence-based psychotherapy for your patients with depression?
Dr. Dudas, you're going to be upset with
me. It's not going to work again.
I did it again. I'm so sorry.
Oh, no. Okay.
So you can answer in the chat. You can answer in the chat if you like. My apologies.
For sure. Okay, let's go on to the next one, Rachel. Thank you. All right. So over the last, I think, as I mentioned before, over the last 20 years, many resources have been put together by American Academy of Pediatrics, by AFP, other groups that really help design care guidelines in order to just help create care pathways and quality indicators for us to better manage depression in primary care. And I think this GLAD, which is the Guidelines for Adolescent Depression for Primary Care, just went through its second update a few years ago. Go ahead on to the next slide, Rachel. So I'll just briefly mention a study, which was the first that I saw to really look at how are primary care providers doing with managing mental health in primary care. This just came out in, I believe, in April or May of this year. And what they found, this was a study looking at a large group in the Bay Area in California. And some of really good things came out of it. One was that pediatricians, pediatric care providers were managing mental health due to the lack of subspecialty care in their patients. So they are taking this on. When they were starting patients on medication, those charts were reviewed by psychiatric subspecialists. And what they found was the decision making that pediatric care providers were making was really consistent with what they would do in subspecialty practice. So at least in the initial phases, primary care really can do a nice job appropriately starting patients on medication. And then thirdly, there was a fairly good uptake of screening tools used to both assess and manage patients within practice. So about 26% were using PHQ and other tools to assess the improvement or ongoing impact of depression on their patients. What they found that primary care providers were not doing as well was that they were not consistently recommending nutrition, sleep, or activity, really lifestyle recommendations, or at least they weren't documenting that. There was inconsistent follow-up and monitoring of medications in primary care, and they were not necessarily documenting recommendations around evidence-based counseling for their patients. So I think this was interesting because it's beginning to show that there's some opportunities, but primary care providers really can help take this on. The next slide, please. Here we go. So I'm going to turn it over to Scott to talk about the quality measure.
Perfect, thanks. So, as Michael points out, this is of national importance, right? I mean, this is something that is important to all of our patients and has tremendous impact, not just on the pediatric life, but as they progress to adulthood. And so, the first step in all of this is identifying who amongst those patients that you're seeing have depression. For those of you who have been around or who maybe participate either in the acute setting or with our adult patients, you're probably familiar with some common spirits, ambulatory and acute quality measures that we've had over the last several years, focused on hypertension, diabetes, sepsis, some of these other measures. This is the first year where we're making a board goal around depression screening. Now, this is really designed as step one in what is expected to be a multi-year process, including not just screening, but in the longer term follow-up and hopefully remission of these patients' depression. But the first step really does start with figuring out who's depressed or who has symptoms that could be depression. And so I'm not going to read this whole slide. There's a lot of information, and you'll start seeing a lot more information being passed around from the national quality team. I know Kelly Batonio and Deb Rockman have been doing a tremendous job of pulling together all of this information. So you'll start to see some of this stuff flowing out from their team as well. But really the takeaway from all of this is that we'll be looking at every patient age 12 and up and making sure that they're screened once a year somewhere within our ambulatory organization. And we're going to be looking at that then for each division and each region in terms of how we're doing on that goal. Next slide, please. Thanks. One of those tools in that toolkit that we're putting together then is really looking at how do we help everyone, right? How do we help the patients be successful with this? How do we help the providers be successful with this? And so really there's this screen, support, succeed idea that we're trying to get out there. So the idea is to start implementing universal screening for all of our patients 12 and up, gather that data, find out who is at risk for depression or who is expressing depressive symptoms. We want to help support those patients. We want to make sure that they feel empowered to take care of themselves, to help have some resources available to them. And then also make sure that the office staff, make sure that the providers all also feel very empowered to help take care of them. I think as Michael points out, we can't send everyone to pediatric psychiatry or psychology. There's just not enough of them out there. And so how do we take care of those patients in the interim? And how do we make sure that our PCPs are comfortable doing that? And we'll share a couple of thoughts here in just a moment. And then really sharing in that success, right? Because the success of the screening isn't about the screening itself. Success is about making sure that we're improving the quality of life for all of those patients who are affected by depression. And so I share this because I want to make sure you're aware there are a number of resources that will be forthcoming both for the adults and for our pediatric lives from our national quality team. Next slide, please. So I want to share a couple of the guidelines and recommendations that the Pediatric Ambulatory Collaborative has been working on. And this has been a labor of love for quite a number of people, done under the leadership of Dr. Greenspag and Dr. Sagar, who've really helped bring together a number of folks throughout the organization to help cull together what should be a starting point for guidelines in terms of managing these pediatric depressed patients. So thank you for everyone who helped us with those. Next slide, please. So the long and short version of what do you really need to know? What you really need to know is, number one, screening is recommended annually for every patient 12 and up, regardless of their risk. We're not intending to just look at kids who might be depressed. We're not just looking for the, quote unquote, moody teenagers. We're really looking for everyone 12 and up, and to start normalizing that practice across the organization, that this is no different than checking a height or a weight or a vaccination status. This is just part of the care we deliver. And then from that, we in primary care are empowered to then start treatment for mild or moderate depression. That may be a lifestyle modification. That might be telling them go take a walk every day, keep a journal, start seeing a therapist. It may be medication. It may be all of the above. But the important thing is that for folks with mild depression symptoms, you're able to start that treatment in your clinic. You don't need to send them out for that. And that's the goal of all of these. The recommended screening instrument for adolescents is the PHQ-A. And this is of a modified version of the PHQ-9 that really asks a few additional questions targeted towards suicidality in our adolescents. It is a screening instrument. It's not meant to be diagnostic. However, it does give us a good starting point to have that conversation with the patient. Gosh, I noticed that you said more than half of the days of the week you're having poor appetite. What's going on with that, or what's behind that? And it may be that, gosh, their dog died yesterday and that's why they're so sad. That person's not necessarily depressed, but they still need some kind of supportive care. And so this is that opportunity to have that conversation as well. Next slide. Thanks. So for the purposes of an actual diagnosis, the DSM-5 criteria are here in front of you. I'm not going to read them. I certainly don't expect everyone to memorize them. If you want to think back to SIGI caps and all of those things you probably learned long ago, they are still valid. But the important thing to know is that to diagnose it, you need at least 5 or more of the following symptoms listed on the right, present in the last 2 weeks with change from their previous base level of functioning. And that one of the first 2 have to be present. So either depressed mood or diminished interest or lack of pleasure in their activities needs to be present. So again, these are folks that you've probably already been seeing in your clinics. These are the patients that mom or dad may be worried about because they're sleeping too much, or their eating habits have changed, or their school grades have changed. So these are folks that likely started seeing already. This is just a way of starting to engage them in that conversation and start working towards getting them well. Next slide, please. So there, within the guideline document that we published, there's a couple of resources talking about medication management. You know, if you look at the guidelines right now, Lexapro or escitalopram is listed as the preferred agent, with Prozac or fluoxetine listed as an alternative to that. But a lot of folks wonder, how do you start that medication? How do I titrate it up? What do I look for? Things like that. And so we've gone to the effort of gathering a lot of that information and putting that into this document as well, so that you know what's an appropriate starting dose, how often can you up titrate the medication, how often are you seeing the patient back in your office while you're doing this, and how do these other adjunctive things like psychotherapy or lifestyle interventions work as a component of their overall treatment plan. So all of that is available to you as part of the document. Many of you, I believe, have it already. If you don't, it's available in the PE library as well. Next slide, please, Rachel. You know, at this point, we're working towards really trying to build that momentum and build that awareness of depression screening, of the resources that are available. And as I said, there's more that are forthcoming, but I wanted to make sure people were aware of the physician enterprise resource library that's out there, wherein you can find a lot of these clinical standards and guidelines. And as Michael had said earlier, a lot of the work that was done on that guideline was derived from the GLAD toolkit and some of these other national standardized toolkits as well. All right, next slide, please. I wouldn't be an informaticist if I didn't at least mention the fact that we are working towards putting this in the EHRs. You know, as those of you who have worked on the adult side know, the data for all of this really has to be discreetly entered into your EHR, and in order for it to be reportable out to some of our larger organizations, our insurance companies, Medicare, folks like that. So we are actively working with the 4 largest of our EHRs, Allscripts, Cerner, eClinical, and Epic, to try to make sure that those forms are available, and that some of this work, you know, as I said, is going to focus on the follow-up aspect of this. So in Cerner, for example, we've started to put forth reminders notifying the providers of a positive screen. So we're looking to make sure that the PHQ-A also triggers that same reminder in Cerner, and where we need to in eClinical and Allscripts as well. So more to come, but that work is in progress. And with that, I'm going to turn it over to Laurel to talk more about the NNCPAP program.
Sure. So hello, everybody. Hopefully you're doing well today. We're sweltering in Texas. Welcome to the heat dome. So stay hydrated wherever you are, and recycle so we can get out of this mess, right? But as you saw in that earlier slide, I'm a unicorn. So it's really cool that you get to talk to a unicorn today. There's not enough mental health providers in the country, and there's not projected to be enough in the next 50 years. And so probably you're all going to keep practicing medicine in the next 50 years. So we really want to talk to you about how the National Network of Child Psychiatry Access Program. I'm not talking. You can't hear me. Can you hear me?
Yeah, now we can. Yeah, I cut out for a minute. Yeah.
I was like, did you hear any of it, or?
Oh, yes. It just was the last 5 seconds.
All right. That was so weird. Okay. I was like, ooh, muted, unmuted.
We heard that we would all be practicing for another 50 years.
That's yes, nobody can retire. Nobody's allowed to retire. No burnout, walkout, quiet quitting, none of that. You got to keep at it. So the National Network for Child Psychiatry Access Network Programs understands sort of where you've been in your life up until today. You went to excellent pediatric or family medicine programs, but unfortunately those programs didn't prepare you for mental health. My dad is a family physician, and if I hadn't done psychiatry, I would be in family medicine. I love the relationship building that you can do in pediatrics and family medicine, and those longitudinal relationships that you have are so special and meaningful. And this is where we're going to capitalize on that But what you didn't get in your training programs was you didn't get how to help assess, diagnose, and treat mental health disorders. So a lot of this you've had to done on your own prior to organizations such as this one helping you out. You kind of had to do it alone. A lot of you in the initial surveys did say that you're doing some efforts related to screening, which is lovely, and we definitely applaud you for it. We want you hopefully to do more of it. But some of you are still in the hesitant phase, it sounds like, with actually initiating some treatments. And that's okay. That's what we want to say, is that we're okay wherever you are in that journey. That's what a psychiatry access program is for. Whether you're already screening and you're already starting to make diagnosis and treatment plans, but you're stuck or something's not working, or you're not even at the point yet where you feel comfortable screening and you want to sort of talk through something first. The programs that are available to most of the states across the country are up and running now, and they're for you. So this slide here is what I'm talking about. And the idea here is that your team has some of this vetted materials for you in their network, but you can also just go to the website that Rachel stuck in there, and you can look and see real quick where if your state currently has a network. 46 of the 50 states have a network that's available to all providers in their state. Unfortunately, a few of you today did list some states that don't yet have them fully in your state, or they don't have it yet. But HRSA has made this an area of priority, and some of those states that don't have them yet are actively working to get the funding to get the work done. So if you are in a state where this doesn't exist just yet, lend your name to the call to get your state funded so that they can provide this kind of network. So what do? We understand that pediatricians and family docs didn't learn this stuff, and you're having to do it on the fly. So we are your preceptorships. We are the unicorns that you can talk to Monday through Friday, 8 to 5, right away. In Texas, where I'm in, where our CPAN network exists, you can speak to a child psychiatrist within 30 minutes of wanting to speak to us. I mean, where can you get that anywhere else except a pizza delivery, right? Except we hope that this will be just as meaningful for you and doesn't raise your cholesterol, because nobody's supposed to eat pizza anymore, right? Which I love it. So we want you to see how we can work in your day, and not that you have to work around our day, because we know how busy you are day to day. So what can you get with an Access Network program? Again, for someone like me in my training, it was so much involved with your faculty, your preceptors. You're all super smart people. You can go read a book, you can go look at an algorithm, and I encourage you to do those things. But sometimes you just want to talk to somebody. You just want a 5-minute or less conversation where you go, you know what, here's what's going on. Here's what I think I want to do. Do you think this is the right route or not? What other suggestions you have? It can be as simple as that you just want to get another person saying, yep, that's going to work. Or how about think about this, or how about think of that? Or if you're not even exactly sure what to do at all, then you're just going to talk to us and we can help you there. So these networks help you with kids, and we use the word kids loosely now because we all know that our brains stop developing at age 25. So we know that we're going to help you whether the kid's 6 years old, 16 years old, or 21 years old. So almost all of our programs across the country will help you with people up to the age of 25. And for those of you in family medicine and even in peds with women, a lot of these programs also have a perinatal aspect as well. So if you're needing to help a woman who's just recently given birth or is planning to have a baby and has some issues that relate to mental health, a lot of these networks also are standing up women's perinatal programming as well. So we can help you at any age of the spectrum at this point. So we help you with whatever you need. Every one of these services offer real-time peer consultation. As I said, you can pick up the phone, ask for help, and you'll get connected with a child psychiatrist, this unicorn. We're actually super nice, and we want to be part of your herd too. And we're not trying to turn you into psychiatrists. We want you to be psychiatry adjacent, because the head is not cut off from the rest of the body, folks. And so we understand that you didn't get that training at the outset, but we're here to help train you on the fly. So we can do these peer time consultations with that question that you have. We also can provide vetted community resources and referrals. So your team doesn't have to spend the time calling out to the 20 places in your area to see what insurance they take. Are they taking patients right now? Or how long is it going to take? Our team will do that for you after you give us information about what's going on. We'll go research it and come back to you and say, here's what we found in your area, neck of the woods. Now, again, reminding you, the resources are still thin on the ground. So as much as we can help you do things within your scope of practice, that's kind of our major core focus. And to that end, we do a ton of training and education. So for example, in Texas, in any given month, we have 12 to 15 CME activities per month across the state that anybody can participate in to learn about a wide variety of topics related to mental health, including about how to do safety planning for youth that are suicidal. So there's a lot of work that goes into CPAN that's beyond just you picking up the phone and calling us. So that's what we want you to do. So I have a call to action for you today for those of you on the call. I would like you to maybe go to your access program, and you can either get it through your own team's way, right, that they have it up here at the top, or you can go to that website that Rachel put up, find your state. And yes, a couple of you are going to feel sad, and I'm sorry in advance for the ones who will feel sad, but hopefully more of you will not feel sad because you'll see your state has it, you'll click on it, you'll see the phone number, and I would like you to put that in your phone today. Here's the phone number for my access network. So the next time you're in your office, you're not quite sure what to do with a kid, an adolescent related to depression or anything related to mental health, you can go, you know what, Laurel told me about this. I'm going to give it a whirl. I'm going to try. Call us up and see how we can help you, because we understand that you need help to feel comfortable and support. The final thing I want to say is that families appreciate when you do this. We actually have studies that show that when a primary care physician tells a family, you know what, I'm going to need to get an expert in conversation, involved in this. Let me step out of the office, let me call CPAN, or let me call MCPAP, or whichever one state you're in. Families actually trust you more, knowing that you care enough to take those next steps to figure out what's the best thing to do for them, that they are supportive of the fact that you don't always know everything, but as a primary care doctor, they know that you've got their back, and it makes that relationship even stronger with them. We also know that they're more likely to follow your recommendations sometimes than they are the specialist. So really having you feel comfortable to do things and having the confidence because we're supporting you on the back end, really in the end is helping those kids get better. So I really appreciate the opportunity to tell you about these programs today. Yes. So please, please, please find out if you're in one of those states that has one, get it into your phone and consider calling today, or the next time it comes up, pulling that number up and calling.
I think that is the end of our slide presentation and a good time to pause. Thank our speakers for giving us such good information and a variety of information, and really opening the floor up for questions, comments of our audience regarding the information you received, or ideas, or questions maybe regarding your screening experiences, so forth. So again, feel free to unmute yourself and add your comments.
Or you can put it in the chat if you're shy.
I always have questions. Laurel, can I ask another question?
Uh-huh.
So for, I think you mentioned that you do like echo programs in
Yes.
Texas, and are there, well, one question I had was, are any of the CPAN educational offerings, are they only limited to people within your state, or are they available across states? Because it seems like different states are doing some pretty incredible programs, and the same thing with the echo collaboratives.
So we have discussed this in Texas, and at least for Texas, I can say the answer is we have been open to the idea of somebody from another state registering and coming to our CME activities. So the CME activities, yes. Related to if you're practicing medicine in another state, we don't feel comfortable recommending what to do for an actual case. So the consultation call, you need to be sitting in the state of Texas, but the CME activities, absolutely. So you could lurk on our webpage, see when we have our sessions. Again, because we know that physicians are busy, Most of our offerings are in the lunchtime hour in Central Time, although El Paso is one of our hubs, and they are in Mountain Time. So if somehow Mountain Time gets you closer to your day where you might have a break in your day, go for it.
That's great, because so some of these might be an educational resource even for folks who are practicing in states that don't currently have a CPAN program. Is that fair?
Yeah, you could pick one that's adjacent to you. Again, a lot of them are pulling up these types of like algorithms, CME activities, other ways to kind of support you, so that even if your state's not quite doing it, you could go to Washington State or Oregon States and look at theirs and get enormous support in that regard.
Thank you.
Well, that's good. What other questions do folks have on the call? Feel free to unmute yourself.
I'm not, this is Gary Greenspike. I'm not sure this is a question or a comment, but in the preceding hour today was call number 2 of our annual goals for Common Spirit Health. Many of you may have been on that call, and we talked about both adult and pediatric depression screening and treatment. And one of the things that dawned on me is the importance of getting this information to the primary care folks on the front line, some of whom are on the call today, but a lot of your colleagues may not. And so one thought that I had as we were having the conversation earlier this morning is to really bring this back to your clinical meetings, take it to your site lead or your physician medical director or APP director, or whoever is your clinical leader in your clinics, and ask them to review this. And we have these videos, of course, and we have the toolkits that Rachel and Dr. Sagar and the whole team have helped put together, and Scott, Michael Dudas, and so forth. But bring those back to your clinical meetings and see if we can get people in the front lines more engaged. I always worry that we have calls like this. We show the information, we say there's a nice toolkit, and people go, yeah, I think I'll go back and look at that later. And of course, day goes by, and another day goes by, more crises happen, and it never happens. And so I think if we could ask the clinical leadership to really help drill that and spend time. We spend a lot of time in clinic meetings talking about all kinds of stuff, most of which aren't clinical. But I think if we could do that, we'd do well. So just an advertisement, I guess, more than a comment. It looks like Andrew has a comment too.
Yes, I do. I'm sorry, I'm working on a phone, so I don't have camera. I actually wanted to reference the diagnostic criteria. And for the record, I'm a clinical social worker, so not an MD. But one thing to note when looking at the diagnostic criteria for major depressive disorder specifically is in adolescence, it can often present as an irritable mood and not so much as a depressed mood. And sometimes, I don't remember if the PHQ-8 covers that or not. But that is one thing that I tend to look for if I'm doing an interview is, if there are periods of irritability that might be linked to a depressive episode, not so much a feeling down or depressed.
Yeah, that's a really great call out. And you're exactly right. The question on the PHQ-A is, over the last 2 weeks, have you had episodes of feeling down, depressed, irritable, or hopeless? Which is a little bit different than the PHQ-9, where I don't think irritability is on there. But you're exactly right. And Michael kind of points out, kids are different, right? They're not little adults. They are actually people that are of their own ilk. So that's a really important call out.
And this is where I say the importance of screening. I think you mentioned it earlier, Scott. Screening is meant to be universal, because you don't always know just by looking at somebody if they're depressed, if they're suicidal. These are things that you can't tell. Definitely in the adult literature, we have pretty significant data that tells us that people within the next 3 to 6 months of dying by suicide have gone to see a physician, and you don't know it. So this is why we really want to, like you said, normalize it. It's just a set of questions we ask everybody, because until you ask, you don't know. Thankfully, I did not go to superhuman school. I don't have superpowers, because I would never want to read minds. It sounds like the worst superpower ever. So because none of us can read minds, we need the screening tools. And so I agree that having the screening tools be easily available to you and put into the EMRs so you can look at the data is very, very critical. But at the same time, we have to be careful about our biases, because the other thing that's we see a lot with the bias is not diagnosing depression in young people of color. And so really making sure that everybody is getting screened. And that way, if they were feeling whatever they might be feeling, then you can start that conversation.
Yeah, I did notice, let me turn my camera back on here. I did notice in the statistics, Michael, that you presented this morning, I think it was Black patients who are kids have lower incidence of depression. And I wondered if that was really true, or if that's just what our data shows.
Yeah, it's probably a better question for Laurel. One thing I did note was that if you look at that data on the far right, it was I think people that identify with two or more races at 29%. So that may be part of the answer there. It's maybe sometimes under identified and but real and there. Yeah.
I thought it was a under identification issue.
Yes, and they're more likely to get diagnosed with a conduct disorder or some kind of disruptive behavior disorder. Going back to the other Andrew's point about irritability, and what does irritability look like? So, but this is said, we're not trying to turn you into child psychiatrists. I'm always careful. I don't want to scare you like, oh my God, I have to remember this, I have to remember that. No, you don't. You just have to remember the phone number to call us, and we'll walk you through it. And just like when you were in residency, although you're getting paid way better than you were as a resident, you will have an attending physician that you can speak to who's not grading you, who will help you think about what to do next. So this is where we want you to understand that some of this stuff is things that you will learn in collaboration with your CPAN provider team, and that as you get more comfortable with it, you might be able to do more. You're getting a special thing I didn't say an hour ago. We do also have evidence that doing these types of programs does bend the curve, to Mike's point, like more than half of kids actually don't get treatment. This was more in the perinatal space, but they're able to show that as OB-GYN started to use these types of networks, they were able to increasingly meet the needs of the women that come to their clinics. And actually they started to be able to do more complicated things. And we're able to do things that maybe initially a year or two ago, they wouldn't have even felt comfortable with. And now they're like, you know what, I can do that, I got this. So medicine is so much about see one, do one, teach one, that we really want to try to have these collaborative networks be about that. We are your support team. They're all state funded. They're not going to bill you, bill the patient by and large. Some of them that do the direct consult to a patient's family do bill. In Texas, we don't. But for the peer-to-peer consultation piece, it's completely state funded. And we also will say, you can put Laurel Williams' name down in the chart and say, Laurel Williams Unicorn said that that this would be okay to diagnose this and to give that. And then for many people, that also just helps them feel a little bit more comfortable. Because at the end of the day, there's just not enough of us. And as a mom, I really want all kids to get the care that they need, and not more care than they need, right? But the care that they need. And primary care is just an essential piece of that.
And Laurel, I think you mentioned this earlier too, but a lot of people are concerned about how much time this takes out of their practice, right? They're already busy. They don't have time to actually go and screen and intervene and do all these things. And I think you had a great point earlier that as you get more accustomed to these things, it doesn't take more time. It's like everything else. It's just part of your routine. It's just part of how you take care of patients. And I think that's really important for providers to hear.
Absolutely. Again, when I have the sort of mild to moderate cases come to my office, which frankly, although I love it because it makes me feel good, I get some wins in my day, so to speak, I'm really kind of in my head like, this kid really could be seen somewhere else, because it takes me 10 to 15 minutes. Because it's relatively straightforward. There's not 10 different comorbidities, and we're making progress. They're getting better. We want to give those wins to you, and then it gives us more space for the ones that are more diagnostically complex. They're not really responding to treatment. There are other things outside of many people's control that are making it difficult. Give us room in our schedules for those, and then we'll let you have the wins because we know how busy you are. So we're like, yeah, we'll give you the wins. And then we'll be able to have space in our clinics for the more difficult ones. So that's what I would say for sure.
Yeah, and I think in terms of having an adolescent who's upset, depressed, difficult, the parents are there, and you're trying to figure out what to do and not willing to take that step forward to actually take care of and treat the patient. You feel horrible. The family feels horrible. You spent way more time than you wanted to trying to get out of the room. And so I think sometimes we work too hard to not do the right thing, and it's a whole lot easier to do the right thing. And I also really appreciate your comment, Laurel, about people sort of use consultative services like this, and after the third or fourth call, they stop calling because they figured it out, and they felt like they got the license to treat, and that gets people started. And so I think for folks on this call, that needs to be part of the message that goes back to your clinical meetings and your groups, to be sure that they're really that you're really sharing the value of this network. And Rachel, I think you and Dr. Sagar surveyed, I think it's like in more than half the states that we are, there's a similar network. Is that right?
Yes. And we did share that in the chat, the list of states and who to contact if there's a registration, who their representative is as well. So it's not so difficult to try and get access to that information.
In Texas, you can just call 1-888-901-CPAN. We're open Monday through Friday, 8 to 5. If you've not enrolled yet, we'll still help you that day. So we'll obviously kind of work to enroll you after the fact. But if you just have a question, I'm super busy, I don't have that time for that enrollment nonsense today, Laurel, we'll just help you with what you need. Some states do have requirements for you to enroll and engage in some of their CME activities as a part of getting the consultation. So it's a little bit, carrot sticky. In Texas, I think we are more all about the carrots and a little bit less about sticks. Weirdly enough, speaking of my state and the negative a little bit. But yes, what the helpful things, that's why I'm saying, like, go to that website, see what your state provides, put that phone number in, go peruse their their website. Most of the time, because Dr. Sagar asked, like, what do you need? What's the patient's problem? How, where do they live? So in case I need to find you resources, I can look at their, zip code and, what insurance are they on? So if we need to find you a resource, we make sure we find you a resource that will actually work. Some of the consultations like Texas will allow you to offload some of the help, have your nurse call instead. So if what you're really just looking for is resources, you can direct somebody on your team to call and get that process started. But we really want to lean into this idea that it's also not just about helping you find resources. It's about helping you extend your abilities, your scope. And so we would really want you to see that as not just the only thing we do is help you find resources. It's actually that upskilling of you, even if it's just a confidence boost.
Well, we are just about the top of the hour. We want to just make sure that everyone knows about some upcoming events we've got going on regarding grand rounds. Similar to this conversation, also Dr. Piazza mentioned we've got the adult depression guidelines coming out in July. So we'll be talking about those towards the fall in the grand rounds. And also suicidality assessment will also be a training for grand rounds in October. That's on the 13th. So regarding this conversation, we'll be expanding upon it in grand rounds in October. And we'd love to see your faces. And we ask that you just encourage your teams and your colleagues in your markets, bring this information. We will also be sharing the slide deck and the videos. So that way you can, we said, just share that information forward. If there is any questions, you can enter in the chat or you can email me separately. Otherwise, Dr. Greenswag, is there any closing comments?
No, well, first, thank you. But Rachel, when we share this, are we sharing it to the participants, to our mailing list, or to pediatricians and family medicine physicians across the system?
Yes, so we
And they-
share it to everyone that
Good.
we invited, so our physicians, our PE leadership. So it'll be that large blast of folks.
All right. Well, I would just say thank you to the team for putting this together. Dr. Dudas, Rachel, Dr. Sagar, the entire team, Lilia. So thank you to them. Thank you to our speakers, Dr. Dudas, Dr. Piazza, and Dr. Williams. Thank you so much. Really, this was a great talk, and I'm glad I got to be here. And to all of you, thanks for being here. And I just want to leave you with that thought of, please take this back to your clinics and poke your partners and find a way to get them to listen to this and discuss it in your clinical meetings. So I hope people have a great weekend. Be safe. It's July 4th, and hope people have a great and restful time. Thanks very much.
Thank you.
Thanks, y'all.
Yeah.
Bye.